You're listening to Who Said, a Cardiology Board Review series. No fluff, just facts.
This episode is about anomalous pulmonary venous return. Total anomalous pulmonary venous return, or TAPVR, or as some people like to call it, total veins, means that all the pulmonary veins connect to the systemic veins or right atrium either by a common vertical vein or individually. The anomalous connection of TAPVR can be supracardiac, cardiac, infracardiac, or mixed. Supracardiac are when the pulmonary veins anomalously connect to the left innominate vein. Alternative destinations are the SVC or azygos vein. Cardiac are when the pulmonary veins drain into the coronary sinus or right atrium directly. Infracardiac are when the pulmonary veins form a vertical vein and drain into the portal vein, hepatic vein, or IVC below the diaphragm. Mixed is a combination of connections at different levels. If only a portion of the common pulmonary vein, either left or right, becomes atretic, the persisting pulmonary systemic venous connections form partial APVR, partial anomalous pulmonary venous return. The most common form of PAPVR, or PAPVR, is when the left upper pulmonary vein drains into the left innominate vein to ultimately drain into the right atrium. Again, that most common form of PAPVR is where the left upper pulmonary vein drains into the left innominate vein to ultimately drain into the right atrium. Other forms of partial APVR include pulmonary veins draining into SVC, coronary sinus, IVC, or azygos veins. Partial anomalous pulmonary venous return is almost always present in patients with sinus venosus atrial septal defect. Pulmonary veins draining into the left atrium is not APVR by definition, since that is where pulmonary veins are supposed to go in a normal heart. In partial anomalous pulmonary venous return, LV size and function should be normal as only the right side is affected. The coronary sinus and right ventricle should be enlarged. Many patients with partial anomalous pulmonary venous return have ASDs, specifically sinus venosus ASDs. Like patients with regular ASDs, in patients with partial anomalous pulmonary venous return ASDs, agitated saline injection through the left antecubital vein should demonstrate a pacification of the right atrium, followed by prominent early transit of bubbles to the left atrium and left ventricle, without a pacification of the coronary sinus. When to intervene? It is unusual for a single anomalous pulmonary venous connection from only one pulmonary lobe to result in a sufficient volume load to justify surgical repair. However, if there is more than one anomalous vein and a moderate or large left to right shunt, then surgical repair is associated with a reduction in RV size and PA pressure and can be useful. For anomalous pulmonary venous return, surgery gets a Class 1 indication if symptomatic, Class 2A indication if asymptomatic, as long as the usual restrictions hold. PASP needs to be under 50% systemic pressure and pulmonary vascular resistance needs to be under 1/3 systemic resistance. Let's see what the 2018 Congenital Heart Guidelines say. Surgical repair is recommended for patients with partial anomalous pulmonary venous return when functional capacity is impaired, i.e. symptomatic, and RV enlargement is present, when there is a net left to right shunt sufficiently large to cause physiological sequelae, i.e. QPQS of at least 1.5 to 1, diastolic pressure less than 50% systemic pressure, and pulmonary vascular resistance is less than 1/3 of systemic resistance. That is a Class 1 recommendation. Surgery can be useful for right or left-sided pulmonary anomalous pulmonary venous return in asymptomatic patients with RV volume overload, net left to right shunt sufficiently large to cause physiologic sequelae with QPQS of at least 1.5 to 1, pulmonary pressures less than 50% systemic, and pulmonary vascular resistance less than 1/3 systemic. That's a Class 2A recommendation. Repair of partial anomalous pulmonary venous connection is recommended at the time of closure of a sinus venosus defect or ASD. That is a Class 1 recommendation. That surgery usually involves intracable baffling into the left atrium, a Warden procedure, or direct reimplantation of the anomalous pulmonary vein directly into the left atrium. Now, we should all know about Scimitar syndrome. Scimitar syndrome, also known as vena cava bronchovascular syndrome, has the following features: partial or entire anomalous curved drainage of a right pulmonary vein into the inferior vena cava. It is associated with right lung and pulmonary artery hypoplasia. It is associated with juxtaposition of the heart, and there will be anomalous systemic blood supply to the ipsilateral lung. The anomalous pulmonary vein comes from the right lung, travels into the abdomen, and enters the inferior vena cava opposite to the hepatic veins. So, when you do color Doppler to the hepatic vein, you will be surprised to see a jet of color Doppler with flow directed towards the transducer coming from the opposite direction of flow of the hepatic vein. That is the scimitar vein. Intervention. Surgical repair of a scimitar vein includes direct reimplantation of the scimitar vein into the left atrium, conduit placement to the left atrium, or intracaval baffling. This surgery can be technically challenging with a greater risk of post-operative vein thrombosis than is associated with more common and simpler anomalous pulmonary vein abnormalities that don't go through the abdomen. Let's see what the 2018 Congenital Heart Guidelines say about this. Repair of a scimitar vein is recommended in adults when functional capacity is impaired, evidence of RV volume overload is present, there's a net left-to-right shunt sufficiently large to cause physiologic sequelae with QP/QS of at least 1.5 to 1, PA systolic pressure is less than 50% systemic pressure, and pulmonary vascular resistance is less than 1/3 systemic. That is a Class 1 recommendation. The guidelines allow for surgery for a scimitar vein in asymptomatic individuals as well, as long as there is evidence of volume overload and the left-to-right shunt is sufficiently large. They say, surgery can be useful for repair of a scimitar vein in adults with evidence of RV volume overload with QP/QS of 1.5 to 1 or greater. That's a Class 2A recommendation. Before we end this episode, I also want to touch on persistent left superior vena cava and unroofed coronary sinus. A dilated coronary sinus can be caused either by persistent left superior vena cava or elevated RA pressure, the latter being more common. A persistent left superior vena cava begins at the junction of the left subclavian vein and internal jugular vein and drains into the right atrium via the coronary sinus. The communication between the left superior vena cava and the coronary sinus results from failure of the left anterior cardinal vein to regress into the ligament of Marshall. Persistent left-sided SVC and unroofed coronary sinus usually occurs in conjunction with coronary sinus ASD, the least common of the four main ASDs, resulting in blood traveling from the left atrium to the right atrium via the coronary sinus. The unroofed coronary sinus at the side of the left atrium allows for right-to-left shunting of systemic venous blood flow from the left superior vena cava directly into the left atrium, bypassing the lungs and causing desaturation. It also places the patient at risk for paradoxical embolism. In persistent left SVC, agitated saline contrast into the left arm will result in opacification of the coronary sinus before the right atrium and the right ventricle. That is a key question that can come up on the boards. They can show you this image and ask you to diagnose persistent left SVC and unroofed coronary sinus. That's all I have for you for anomalous pulmonary venous return, total or partial, and persistent left SVC and unroofed coronary sinus.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.